So myself, Dr. Nikita, your radiology educator at PrepLadder, and just get the batteries in place.
Asking questions to 6, 7 lines like this much size questions.
कैमरा कब से स्टार्ट है वो आप सब एडिट कर देना, तब से बंद ही नहीं था. आयो मेरा ही हुआ डिस्कनेक्ट.
So when you say I will start, okay? When ma'am comes back, we'll start.
Hello everyone, so welcome to today's session. This is going to be an interesting integrated session. Hello everyone, so welcome to today's session. This is going to be an interesting integrated session where we are going to discuss a very important topic both from the exam point of view and practically, clinically as well. That is the topic of common bone tumors. So myself, Dr. Nikita, your radiology educator at PrepLadder, along with Dr. Jambukeswaran sir, the orthopedics faculty at PrepLadder, both of us will give you an integrated view into the common bone tumors like we see in our clinical practice. How does the patient present? Then how do we proceed with the radiology imaging? And what is the management, the treatment part of it? All of this we are going to discuss in an integrated way. And we hope that you would definitely like this video. So starting with the first case scenario, over to you, sir.
Thank you so much, Dr. Nikita, for a sweet introduction. We will move on straight to the case scenario number 1. A 13-year-old boy presented with swelling around medial aspect of his left knee joint. The question asked whether are you having any pain. The boy strongly said, I don't have any pain, no pain. He denies it. And he said, definitely there is no history of trauma and it's of insidious onset. Dear friends, you know insidious means the patient doesn't know how it started and when it started. That's the thing. On palpation, a bony, hard, non-tender swelling was noticed on medial aspect of the left lower end of the femur, roughly measuring 5 into 5 centimeters. What could be the probable diagnosis? How to go ahead with the case? Just I took an X-ray and this is the X-ray. And Nikita ma'am will discuss about this now.
All right. So here we have the radiograph of the patient, radiograph of the knee, and which shows us that in the distal femur, we can see that there is a lesion which seems to be arising from the distal femur, and it looks like to be continuous with the femur itself. So it looks like it's an outgrowth from the bone itself. So logically thinking, outgrowth means growing out, out means exo. So this will be an exostosis, which is another name for osteochondroma. So friends, another finding which helps us prove that this is osteochondroma is, look at the direction of the growth of this tumor. So you can see that this lesion here is growing in a direction which is away from the joint. So it is near the knee joint, but it's not growing towards the knee joint. It is growing away from the knee joint. So this is how an osteochondroma looks like. It looks like an outgrowth from the bone, which is continuous from the bone. And if you look at the term osteochondroma, remember osteo means bone and chondro means cartilage. So what is the cartilage part here? Is the cartilage cap. Now remember that we cannot see the cartilage on X-ray until and unless it is calcified. So that is why the part that you are seeing here is the bony part. So what you would see is the X-ray size of this tumor would be less than the clinical size that we palpate. Because when we palpate the bone and the cap also. But when we look at the X-ray, we are only seeing the bony part. And that is why the X-ray size will be less. So quickly summarizing the findings here in osteochondroma that we see here. So this is the femur bone, distal femur, we are seeing a lesion. It is continuous with the medullary cavity of the bone and it shows the cartilage cap. What area of the bone is it involving? Is it involving the epiphysis, the metaphysis or the diaphysis? Right? So epiphysis, metaphysis or diaphysis, you can see that it is involving the metaphysis. That is a classical site. But you can have some exceptions where it can involve the diaphysis and epiphysis, which sir would be talking about ahead. Right? So this is an osteochondroma and outgrowth from the bone. Now, remember that in osteochondroma, there are two types. It can have a pedicle, like it can be pedunculated, like you see here, it has a stalk and then it is going out. This is the most common type. So this has a stalk directed away from the physis. It's covered by the cartilaginous cap. And can this turn malignant? Yes, approximately 1%. Right? So this is a pedunculated osteochondroma that you can see here. Coming to the sessile variant, sessile is more rare and pedunculated is more common. Sessile is associated with something called as hereditary multiple exostosis, and it has more chance of malignant transformation. So this outgrowth that you see here, this is sessile. It does not have a stalk. So this is a sessile osteochondroma that you are seeing here without any stalk. Over to you, sir.
So the most common primary benign bone tumor at any given time is our osteochondroma, otherwise called exostosis. And you see the statistics, 20 to 50% of all benign bone tumors are osteochondromas, 9% of all bone tumors altogether. It is osteochondroma. It is an offshoot from spongy bone tissue covered with cartilaginous cap. Classically, it occurs in metaphysis. This is the rule. As ma'am said already, she said it earlier, some exceptions are there. Very rarely, osteochondromas can happen in diaphysis. Very rarely, it can happen in epiphysis. That I'll show you in the next slide. Most common site is distal end of femur. The second common site is proximal tibia. These two sites, so anyhow, it's around the knee joint. That's the most common site. Many times repeated question, should concentrate. Then, most common age group is growth spurt during growth period, otherwise adolescence. Many times this osteochondroma, the presentation will be around age of 13. I'm telling from my 18 years of clinical practice, around age of 13. So during growth period. And the most common sex, without doubt, it has a male preponderance. Whenever we are dealing with bone tumor, all these facts we should know, because nowadays it's a trend to give either as a clinical scenario or image based, otherwise accept questions. So we should be thorough in all these facts. Then I said there is an exception. So far what we were discussing is called exostosis. There is a condition called multiple hereditary exostosis. This is otherwise called diaphyseal achalasia. Look at this word. Diaphyseal achalasia. So far what we have said, the classical site of osteochondroma or exostosis is metaphysis. There is a condition called diaphyseal achalasia, more common in men. 5 years before the old edition of Apley said equal sex ratio, the latest Apley says it's more in men. So this point again we should concentrate. It's often multiple and growth, it can present with growth disturbance, and the age of presentation of hereditary multiple exostosis is not puberty, it is around 5 years of age. So it is causing growth disturbance. The next variant is Trevor's disease. Okay, so hereditary multiple exostosis happens in diaphysis. Classical osteochondroma or exostosis happens in metaphysis. There is one condition, this osteochondroma can happen in epiphysis. That is called dysplasia epiphysealis hemimelica. Why the word hemimelica? This osteochondromas happens intra-articularly. That means from the epiphysis, it can go inside the joint, and classically this happens on one side of the body. For example, left knee joint, it's happening in left elbow, left shoulder, left ankle, like that. That's why the word hemimelica, okay, on one side, right? So this is Trevor's disease. Asked question. Trevor's disease is this exostosis happening in epiphysis, okay? So it's a variant. Coming to clinical feature, usually it is asymptomatic. Pain won't be there. That is why patients are not coming at early age. The age of presentation is around during adolescence, 13 years I said. Slowly it's growing. Once the patient sees a swelling, which causes disfigurement, they'll come to an orthopedician. And it is, as a rule, it's a hard mass and it is absolutely painless. When pain happens in osteochondroma, certain things should cross our mind immediately. The commonest thing can be an adventitious bursitis. Because we are Indians, when we sit cross-legged, usually it happens around the joint in the outer surface. So constantly that bony hard mass is rubbing against the ground that can cause adventitious bursitis. The patient can present you with pain. That's why I made this as the first cause for pain in osteochondroma. Number two, since there's a growth, it can compress the surrounding nerves and vessels and can cause neurovascular compression. That's the second cause for pain in osteochondroma. Third thing, when fracture happens in osteochondroma, wherever fracture happens, pain should be there because periosteum is irritated. So pain will be there. Last but not the least, dear friends, most important thing, that is why we are very much worried about pain in osteochondroma, malignant transformation. This is very important. Book says it's only 1%, but it's very, very dangerous. So whenever an osteochondroma patient presents with pain, don't neglect them. Investigate thoroughly. Risk factors and signs of malignant transformation in osteochondroma. 1% chance in solitary osteochondroma. If it is hereditary multiple exostosis, the percentage rises to 5. So this was an asked question. That's why with statistics I had given. This was an asked question, FMG question. So it's very important. Then sessile, ma'am told this already. Nikita ma'am already told this. Sessile carries more chance of malignant transformation than pedunculated. Then osteochondroma transform into low-grade chondrosarcomas. And what are the clinical signs, or what are the important things that will tell you that it has gone for malignant transformation? Sudden increase in size, sudden unbearable pain, new onset pain without trauma, no trauma, new onset pain. Number 3, very important, it's an MRI finding. When cartilaginous cap thickness, when it exceeds 2 millimeters in MRI, definitely there's a high chance that this guy is going for malignant transformation. That is why new onset pain in osteochondroma, don't hesitate to do MRI. And obviously, the Supreme Court is pathology department, and we confirm the diagnosis only by biopsy. Then coming to treatment, if asymptomatic, leave it alone. Don't do anything. No pain, nothing, leave it alone. Advise the patient, it's harmless. If there is persistent pain and suspicion of malignancy, surgery is indicated. What is the surgery of choice? Extraperiosteal excision with cartilaginous cap is the treatment of choice. This is the important question. This is the treatment of choice. If suppose malignancy is confirmed, you have to do a wide surgical excision with limb preservation. Okay, so to some extent that completed the topic osteochondroma. Then I'll go to the next case scenario. I will read the thing. Okay, a 20-year-old male presented with pain around the left ankle. He noticed swelling after a few weeks of pain. So what was the initial complaint? Pain. Pain first. Swelling came later. This is a very important thing. And underline the age group. 20-year-old. Underline the sex, male. So pain is the first complaint. These points are very important. Okay, then you see, then comes, and what happens? Again, the swelling is insidious onset. The swelling is insidious in onset, and the patient don't know how it started, when it started. Then on examination, it was a shiny swelling with engorged veins. This point is very important. Engorged veins. Then skin is stretched and shiny. Patient loses weight. Cachectic symptoms are there. What could be the probable diagnosis? How to go ahead? I took an X-ray, and the X-ray picture is like this. Ma'am, please enlighten us with this X-ray.
So yes, let's discuss about the radiological finding here in this patient. So what do we see here is this bone here, this is tibia and this is fibula here. And what do we see is there is some swelling that you are seeing here that the patient also complained. And when we take a radiograph, what we see is there is a bone forming mass. That means a white mass. It is osteogenic sarcoma. That means forming the bone. So you will see this osseous matrix that will be there. There'll be bone formation. And you can see this periosteal reaction here, which is like a sunburst pattern. Now, what does that indicate? That sunburst pattern indicates that it's a aggressive bone lesion. Remember, it can be seen with other conditions also, but what it indicates is aggressive bone lesion. The other types of periosteal reaction, like this is sunburst. You might see perpendicular to the bone, that is hair on end appearance, hair end periosteal reaction can also be seen with osteogenic sarcoma, or it can show the lamellated periosteal reaction as well. So the findings that help you identify that this is osteosarcoma is the osseous, the bone matrix, and you have the sunburst periosteal reaction telling you that this is a aggressive bone lesion. So this is the image that we had seen. This is another image. This is the CD scan with the white bone cortex. Again, you see this sunburst pattern that you are seeing here along with the soft tissue swelling telling you this is osteosarcoma. And in this lesion, you see this periosteal elevation that is like the Codman's triangle. And you see the bone forming lesion here, the bony matrix, the osseous matrix telling you that this could be a osteosarcoma. Right, the common site is around the knee joint again. Okay, the common site is around knee joint. Now, what is the role of MRI in osteosarcoma and overall in bone tumors? MRI is something that helps you to evaluate in a bone if there are skip metastases or skip lesions which are there. Right, that you can see better on MRI with the alteration in the bone marrow signal. Plus, you can see how much is this tumor extending into the extraosseous soft tissue, the neurovascular involvement. All this can be better seen on MRI. So MRI is an essential tool to accurately determine the local staging, right? And to see for the intraosseous tumor extension and the soft tissue involvement. Okay, that's the role of MRI. Over to you, sir.
So now we will see the important facts in osteogenic sarcoma. Okay, ma'am has nicely explained the radiological features. So, as I said earlier, most common non-hematological primary malignant bone tumor. This word is very important. Okay. If they ask most common primary malignant bone tumor, the answer should be multiple myeloma. So you should have always this in your mind while selecting the most commons. No, just don't take it for granted. Read the 4 choices twice, then we should answer. The second most common primary malignant bone tumor. So the first is multiple myeloma. It arises from multifactorial mesenchymal cell. This is very important. Why I'm telling? Again, this was a question. Previously, a DNB exam was there. It was asked in that. Once it was asked in NEET, I'll tell you, the origin of Ewing sarcoma is from endothelial cells of the bone marrow. The origin of osteogenic sarcoma is mesenchymal tissue, multifactorial mesenchymal tissue. The origin of multiple myeloma is plasma cell of bone marrow. The origin of giant cell tumor is from multinucleated giant cell, mimicking like osteoclast, so it's called osteoclastoma. These 4 points we should not forget in malignant bone tumors. Okay, and the most common age group of osteogenic sarcoma is 5 to 25 years. Very important repeat question. Again, the most common site is distal end of femur. The second common site is proximal tibia, that's around knee joint. And the most common sex that's affected is male. Classically, it happens in metaphysis of long bone. So, metaphyseal lesion means osteogenic sarcoma. Diaphyseal lesion means Ewing sarcoma. And if it is epiphyseal lesion, it should be giant cell tumor. Again, gold standard points. However much time we read this is worth reading. Okay. Then coming to clinical features, pain is the first symptom. This is very important, dear friends. In as far as when we are dealing a malignant bone tumor, if pain is the first symptom, the first diagnosis should be osteogenic sarcoma. Other way around, swelling starts first, pain comes little later. That should be a case of giant cell tumor. This is a golden point because nowadays, dear friends, it's a clinical scenario based exam nowadays. They are giving huge lines, 6-7 lines of clinical history. Okay, so whenever we are dealing with, for example, a 20-year-old male presented, that's why when pain is the first symptom, it should be osteogenic sarcoma. And I'll explain the concept why pain starts first. Swelling takes some time in osteogenic sarcoma. We all know osteogenic sarcoma is a tumor which arises from the cancellous bone of the metaphysis. So the lesion starts there. When it grows, and it's a vascular tumor. When it extends, when it touches the periosteum, pain will come. But in the initial phases, it's well contained inside the periosteum. When it's inside the periosteum, obviously swelling won't come. When swelling comes, when it exceeds the periosteum, comes out to the soft tissue, the patient will notice the swelling. So that is taking time. That's taking time. The pain which is experienced in the very beginning of the disease is the stretch pain caused by the periosteum. That is the concept. That's the concept. And skin over the swelling is stretched. It is shiny. It shows tortuous vessels, engorged veins, because osteogenic sarcoma. Sarcoma means a vascular tumor, highly vascular tumor. Okay, yes. And swelling is firm to hard in consistency. And why we are among tumors, bone tumors, why we are very scared about osteogenic sarcoma? It spreads to the lungs very fast. Hematogenous spread. That's the reason. Okay, that's the reason. We have to diagnose it as soon as possible and should go for aggressive treatment. Otherwise, we will lose the patient very soon. That's the problem. That's why it's very dangerous. And secondary osteogenic sarcoma. So far, what we had said is a primary osteogenic sarcoma. Certain conditions can predispose osteogenic sarcoma. Very important predisposing factor, dear friends. Several times asked question, Paget's disease of bone. Paget's disease of bone is a very important predisposing. Paget's disease, we know it's otherwise called osteitis deformans. Okay, so that's a very important predisposing factor for secondary osteogenic sarcoma. Number 2, irradiation. When you give excessive radiation, aptly says more than 2,000 rads, more than 2,000 rads. Okay, very important predisposing factor for osteogenic sarcoma. Hereditary multiple exhastosis, otherwise called diaphyseal achalasia. We had seen there is usually, if it is solitary, it goes for chondrosarcomas. Hereditary multiple exhastosis is exemption. It can get converted to osteogenic sarcoma, very rare. Okay, because exhastosis, what we read, it is from cartilaginous origin. You see, this is the twist. Okay, so please register this in your mind. Then never underestimate chronic osteomyelitis. It's an infectious condition. Notoriously, the latest book I recorded, it's untreated chronic osteomyelitis is a predisposing factor for osteogenic sarcoma. Last but not the least, bone infarcts. Okay, infarct in the bone can predispose osteogenic sarcoma. All these things, these 5 points, you should remember. And coming to management, early and radical ablation is the surgery of choice, and main treatment is amputation. Amputation, even today in 2024, remains mainstay of management. So the levels of amputation, just I will rush through. Upper end of humerus is the lesion, you should go for 4/4 amputation. If it is the upper end of tibia, mid-thigh amputation. Upper end of femur, you should go for hind-quarter amputation with hip disarticulation. And if it is lower end of femur, you have to go for mid-thigh amputation with hip disarticulation. All these are very important. And coming to radiotherapy, radiation is it's given preoperatively to decrease the viable cells and get disseminated into the bloodstream. Okay, to prevent metastasis. Okay, so radiation is very important. Total dose is 6,000 to 8,000 rads, 2,000 rads per day or 1,000 rads per week. Okay, this is the regime. And chemotherapy, this is an asked question. It's given pre-operatively and post-operatively to control micrometastasis. And the drug of choice, there is no single drug of choice. Certain drugs are used. Very importantly, even now, methotrexate remains the first. Citrovarum factor, adriamycin. Each and every drug has its own side effect that pharmacologists would have taught you. Methotrexate, potential to cause bone marrow suppression. Citrovarum factor, adriamycin, notoriously cause myocarditis and cardiomyopathy. Endoxin is one drug, and cisplatin. These are the drugs that are used. Latest techniques that are tried are limb salvage, tumor endoprosthesis. It's not latest, the past 10 years, 1 decade we are doing, and in our center we do this. And immunotherapy, this is really very recent one. Just I have read and I have never tried. The sensitized lymphocytes from survivors' blood are infused into the patient, which improves the immunity of the patient. This is a very current thing, so far unasked in any of our Indian entrants, so be aware of this. Then immunological status improved by giving BCG vaccination. This is a Bayesian point. Old point, but a golden point. The immune status is improved by BCG vaccine. We all know BCG for tuberculosis. Okay, BCG improves the immunity of osteogenic sarcoma. One more plus point I want to extra point from general surgery, because this is given in Bayesian law. Okay, I want to give that. BCG vaccination improves the immune status in bladder carcinoma. So 2 carcinomas, the immune status is improved by BCG vaccination. Both are asked questions. And allogenic sarcoma tumor cell vaccine, this is the latest. Okay, so this is about, in short, about treatment of osteogenic sarcoma. With this, we close osteogenic sarcoma, and prognosis is, see, without treatment, death happens in 6 months to 2 years. When you do combined approach, that is amputation, chemotherapy, radiotherapy, that's called combined approach. 5-year disease-free life is more than 70%. Really, that's very good. So the take-home message, dear friends, we should try to diagnose osteogenic sarcoma as soon as possible, and we should treat it aggressively. Okay, then coming to the third clinical scenario, a 30-year-old male presented with swelling of insidious onset over the left wrist. Vague pain appeared 2 months after swelling. So swelling, okay, came first. Swelling came first. Patient attribute that pain to trivial trauma. On examination, a shiny skin is seen, but no enlarged veins. What could be? On palpation, classical, the doctor, I felt an eggshell crackling sensation. What could be the probable diagnosis? How to go ahead? I took an X-ray. An X-ray shows this. Nikita ma'am, please enlighten us.
So, all right, here we are with the radiograph of the patient, the wrist radiograph that we are seeing. And what do we see on the radiograph is there is an expansile lesion that we are seeing in the bone here. And this expansile lesion, it is touching the articular surface of the bone. How is the growth plate? The growth plate is fused. So this is a fused bone. It's an expansile lesion. Is it involving the epiphysis? Yes, it is reaching till the bone end. So first point, remember that this tumor is involving the epiphysis. And if you know the mnemonic for the epiphysis lesions, remember ECG. ECG, epiphysis involving is chondroblastoma and giant cell tumor. How do we differentiate the two? Is chondroblastoma, blastoma generally in young patients, and giant cell tumor, remember giant for giant, it occurs in a giant person in an adult generally after 30 years. So this is a fused bone, expansile lesion. Remember, giant cell tumor makes the bone giant. That means expansor bone occurs in a giant person, that's an adult after 30 years. And giant involves the joint, that is the articular surface. This is the tumor which can cross the growth plate and it can reach at the articular surface. And if you look at the tumor here, you can see this multiple trabeculations, the septated like appearance, which is called as what appearance? This is called as soap bubble appearance. Okay, this is called as soap bubble appearance. And remember, this is not specific for giant cell tumor. A very similar tumor, that is aneurysmal bone cyst, also can give a soap bubble appearance. We'll discuss that ahead. How do you differentiate giant cell tumor from aneurysmal bone cyst? And remember, for giant cell tumor, the wrist radius is a very, very common site. And remember the risk factors for the local recurrence from the radiology aspect. If you see that it is extending to the soft tissue, then there's a risk for recurrence. It is very close to the articular surface, less than 2 millimeters, and the cortical bone. If this is a tumor, the cortical bone, the thickness is very less. It is less than 3 millimeters. All these are the risk factors for the local recurrence. Remember, giant cell tumor, more than being malignant, it's more like a local aggressive, and very rare cases it might show metastasis, like it can turn malignant as well. Otherwise, it's more like a locally aggressive tumor. Over to you, sir.
So, let us see the important facts in giant cell tumor. This is otherwise called osteoclastoma. Okay, because the multinucleated giant cell, which is seen in the histopathology, exactly looks like an osteoclast. So, it's called osteoclastoma. And the most common age is 15 to 35 years. This is the correct range. Okay, right. And it has again a male preponderance. The most common site is again lower end of femur and upper end of tibia, that's around knee joint. And though it is benign, it behaves locally malignant. And classically, it occurs in epiphysis of long bones after epiphyseal closure. All those things ma'am have highlighted very well. And you see, coming to giant cell variants, this is very important, dear friends. Chondroblastoma is the first differential diagnosis, and very difficult to differentiate giant cell tumor from aneurysmal bone cyst. Aneurysmal bone cyst is not a true tumor. It is an hamartoma. It's faulty formation. It's an hamartoma, harmless condition. We had seen that in hyperparathyroidism brown tumor. Fibrous dysplasia, again, it's a differential diagnosis. Non-ossifying fibroma, adamantinoma, which happens in the mandible, that again, it is a differential diagnosis. Now, ma'am will tell us how to differentiate giant cell tumor from aneurysmal bone cysts.
Right. So a very, a difficult differential diagnosis, giant cell tumor and aneurysmal bone cyst. Now, radiological perspective, if I talk about it, remember that we said that giant cell tumor, giant occurs in a giant, right? So that means this occurs after the fusion of the growth plate. And we said EEE, this occurs in the epiphysis. Exactly opposite of this, generally this aneurysmal bone cyst occurs before the fusion, and it occurs in the metaphysis. Aneurysmal bone cyst, is it expansile? Yes, like an aneurysm, which is a dilated, expanded vessel. Similarly, aneurysmal bone cyst is like an expanded bone. So remember, both of these are expansile lesions. Both of these can show soap bubble appearance, but the difference is the age and the location. This is before fusion metaphysis. This is after fusion epiphysis. This is a very important point that we should remember, and both of these can show fluid levels on MRI. Giant cell tumor will have a more solid component that on contrast scan. If you do a contrast MRI, it will show enhancement as well. So it will have more of a solid component. That is what we need to remember here. Right? Over to you, sir, if you want to add anything regarding the differentiation in between the two.
Okay, thank you, ma'am. Just you have enlightened everything. Everything was explained, the difference between giant cell and aneurysmal bone cyst very practically. See, aneurysm means something concerned with the blood vessel. Aneurysm, a dilated blood vessel. Blood vessel 100% should be having blood. Blood should be having hemoglobin. Hemoglobin should be having hemosiderin. When multinucleated giant cell mixed with hemosiderin, it is aneurysmal bone cyst. Only multinucleated giant cell, not much of hemosiderin, not able to see much, then it should be giant cell tumor. That's why my professor used to tell me, in the histopathology, when you see hemosiderin, it's a good sign. Okay, that's all. This is how we should differentiate radiologically and confirm with histopathology how to differentiate giant cell tumor from aneurysmal bone cyst. Coming to clinical features, swelling is the main complaint. Pain comes much later. Usually, many times pain won't come. When pain happens in giant cell tumor, a sudden onset pain in giant cell tumor, suspect a pathological fracture. This is the teaching. Because already it's eroded the thing, and cortex has become very thin. So trivial fall. See, you won't believe. Day before yesterday, a girl came to my OP, fall on outstretched hand, and on examination, there was nothing, no swelling, nothing was there. Took an X-ray, I was able to see an osteolytic lesion with pathological fracture. A young girl fall on outstretched hand usually will not cause fracture. It happens only in elderly postmenopausal women. So that was a trivial fall inside her house, and that was not a simple fracture, it was a pathological fracture, and it proved to be a giant cell tumor of distal end of radius. That's why sudden onset of pain, you suspect pathological fracture. Skin over the swelling looks shiny but no dilated vein, because it's not a vascular tumor like your osteogenic sarcoma. On palpation, because of microtrabeculations, it just gives an eggshell crackling sensation, a classical clinical sign. That is, and this is just for theory's sake. Whenever you comes a swelling like that, you should not press and you should not try to elicit the eggshell crackling sensation. That means you are inducing pathological fracture. Okay, so this is for just academic interest. Although, as I said, although GCT is benign, pulmonary metastasis have been recorded in 3% of cases. One good thing is, when you remove the tumor, the metastasis goes away. This again was an asked question. I just add an extra pathology point for you. You are removing the primary tumor, metastasis is disappearing. Think of GCT, think of renal cell carcinoma, RCC. Okay, yes, we'll move on to the treatment, the final part, simple curettage. This is the standard method of treatment. Simple, just curating out the lesion, but recurrence is there, recurrence rate is there. So extended curettage, what is that? You are using a power drill, 1 to 2 centimeters widely, you are curating it out, but you are removing lot of bone, so a dead space will be there. That itself can cause pathological fracture. So curettage, it can be filled. If it's a small gap, if it's a small cavity, fill it with cancellous bone grafting. If it's a huge cavity, where to take a bone? From iliac crest, when you just go on digging the iliac crest will become very shallow and it will become a cavity. Okay, so if it's a huge space, it's a huge cavity, that should be filled with bone cement. That's PMMA, is polymethoxymethyl acrylate. That's nothing but the bone cement, right? Then if in inaccessible site, okay, or like your pelvis and spine, you can't go and do curettage. Okay, just embolize it. Okay, embolization. Let's go and block that itself will get waned away. Then local irradiation only for inoperable lesions. Bisphosphonates as a surgical adjuvant. Really this is very helpful, and this was an asked question in pharmacology session. Bisphosphonates, it's a one of the drug that's used, very useful as a surgical adjuvant for giant cell tumor. Last but not the least, dear friends, denosumab. Giant cell tumor means you should not forget this drug, denosumab. Mab means monoclonal antibody. Denosumab is what is the mechanism of denosumab? Denosumab increases the maturation time of osteoclast, and it delays bone resorption, so some new bone can grow inside the cavity. Okay, so denosumab is very recent, not recent, 5 to 6 years they are trying with very good results. Okay, to some extent we have completed giant cell tumor, and this session over to ma'am. So ma'am, you are the sweet person to say thanks, vote of thanks to our guys. Guys, all the best guys. I'll hand over to ma'am.
Thank you so much, sir. It was a pleasure, sharing the stage with you and having this integrated session. There's a lot of things that even I have learned from you. The orthopedics aspect of the bone tumors, and I'm pretty sure so have the students, and I hope they have loved this session, the integrated approach to bone tumors, the most common bone tumors that we see clinically and in exams as well. So thank you so much, everyone, and all the best. Take care. Thank you.